Welcome back. PTAC, I'm Dr. Lee Mills, one of the co-chairs of PTAC. Kristen and the PCDT, as well as Kaushik, laid the foundation for this public meeting and some of the questions we want to explore. Now excited to welcome four esteemed experts to share their perspective on improving data infrastructure to empower patients and providers. You can find their full biographies and slides posted on the ASPE PTAC website and the public meeting registration site. At this time, I'll ask our participants to go ahead and turn their videos on, and I see you have. Thank you. After all the experts have presented, the committee will have plenty of time to ask questions and engage in what we hope will be a robust discussion. First, we're pleased to welcome Mr. Mark Scrimshire, Chief Interoperability Officer at Onyx Health. Mark, welcome.
Okay, good to be here. So I'm going to take about 5 minutes and hopefully give you a bit of a rapid history of interoperability over the last 15, 16 years. And hopefully my co-presenters here will take us forward. First, let me cover my background and where I sort of fit in. I've been co-chair of the Da Vinci Payer Data Exchange work group. We cover things like provider directory, formulary implementation guides, but also Payer Data Exchange, which is actually cited in the CMS 0057 prior authorization regulations. I'm also co-chair of financial management and a board member of the FHIR Business Alliance, where we're really trying to promote the use of FHIR. So that's a bit of sort of framework of where I'm coming from. Let me tell you just a little bit, if we go on to the next slide, of why should I be here, I suppose. Working at Onyx, I was the first person on the what became Blue Button 2.0 API at CMS. And we have built a platform really primarily for payers that enables those payers to actually comply with the CMS regulations. And we very much are supportive of the work going on in HL7, in the Karen Alliance, the Da Vinci accelerators, and elsewhere. And we're lucky to have a very esteemed board that also includes Graham Grieve, the father of FHIR, that really enables us to accomplish a lot of this interoperability. So let's move on and actually talk a little bit about interoperability. And I started from this point. I know there's been a big initiative about killing the clipboard, but we really need to get beyond that. I know, we have invested billions in trying to achieve interoperability, but how often do you end up in the doctor's office and you're presented with that clipboard and you have to pass that memory test of all of the meds that you're on, every procedure you've had since you were a kid? I know I fail every time. There has to be a better way. And that's really what's certainly driven my passion for enabling and empowering patients through the basics that we need, which is interoperability. So let's move on to the next slide. And here's really the core, that what has happened really over the last 16 years. We started back in 2009 with the high-tech and meaningful use. And that was rapidly followed by Blue Button 1 and the enhanced Blue Button Plus. Then we started to see real initiatives happening around FHIR. And that continued. And so when we launched CMS Blue Button 2 back at HIMSS in 2018, that was really the first major API. It enabled 53 million beneficiaries to be able to access primarily their claims data from CMS in a structured form. So instead of having 1,700 pages of just text file, you now have structured data. That led to CMS 9115, the Patient Access API, which really drove payers to have to implement Patient Access API to enable access to their claims and their clinical data. It also made provider directory openly available and your formulary. So think about that when you are thinking about moving health plans. Potentially you could have apps that could look at the formularies to understand the drugs that you're on and how they fit within your health plan's proposed offerings, and whether your provider is actually in network critical things that you want to understand when you change from one plan to another. And so that we've had that in place for 3 or 4 years. Now we're seeing a couple of real key themes. We saw TEFCA released in 2022, and that is now starting to go live and really starting to be used. And we also had the prior authorization rule from CMS, which affects potentially about 900 plans across the country, on really delivering a standard prior authorization API so that providers can get an answer in a consistent manner about whether a prior auth is required, and if so, what data they need to provide in order to get a decision. But it also expands the use of that patient API. You would be able to get those prior authorization details through that API. Also, it enables providers to access information from the health plan about the members they're treating. And then, as we know, we as patients tend to move from one plan to another. Wouldn't it be great if we could take our health history with us? So build that sort of longitudinal health record. That's the payer-to-payer API. And that is really going to drive significant more utilization of this data that can flow across the system, particularly between providers and payers. So we'll see that rule go into place in 2027, but we've also seen HTI-1 and HTI-4 go into place. So in 2026, we're going to see the core US clinical data, particularly in its FHIR representation. So US CDI version 1 will be replaced by US CDI version 3. That means US core, that the structured data version of that interoperability data set will move to US Core 6.1. And so we're raising the bar, expanding the amount of data that's going to be available. And then in 2027, we're seeing all of those CMS APIs will go live on January 1st. So we're expecting that increase in the amount of data that's going to be flowing through between providers and payers particularly. Let's move on to the next slide. So thinking about this in a slightly different way, what have we seen is the expansion in the amount of data available. And I know my friend and colleague, Kristen, will go into this in more detail, but we initially had HL7 v2, and almost every implementation of v2 was just subtly different. And so it created a barrier in itself. Then with HL7 v3 or the CCD and CCDA formats, we saw structured documents that were somewhat computable, but again, pretty complex to exchange. And really, I think back to some of my history of while I was at CMS and being involved in conversations where it says, how much data should we put into a document? It's sort of a crazy concept. You really want to be able to access the data that you need. And that's really what has been happening with this transition to FHIR, in that we're seeing more data, but it is also more granular. So you can actually go and ask a question. If, for example, I want to see the A1C results for this patient, you can make that inquiry and just get the discrete data that you want. And that means that we can be far more focused. And I think as we look at bulk exchange of data as we go forward, I think it's going to get more targeted rather than just being blanket. It'll say, give me all the data you've got for all the members that I have shared with you. We need to become more explicit about the data that we want. But at the same time, with the EHI rule and the information blocking rule, we're seeing this scope of data that is going to be available just continuing to expand. And so this has been the journey that we've been on. And hopefully now patients are really getting to the point where they can make use of this data. If you see how patients are now starting to use AI to understand the data that they have at their fingertips, this is just an ongoing journey, and we're going to see more and more data broken out. So let's go to the next slide. I'm going to keep up the momentum here. We are starting to go from just data and being able to move data. And I'm not joking when I said with the original Blue Button 1, it was transformative, but printing out your 3 years worth of health history on simple Times Roman pages, you literally ended up with hundreds and hundreds of pages of data that you couldn't easily do anything with. So we got better. We got that into more of a structured form. So now we really have information, but we're really on the cusp now of turning that information into insights. And I think there's another important thing that is coming here. Let's go to the next slide. It's what I call really the we've had this experience gap, right? So we've had patients are now able to tap into more data. I know the data that I've got on my phone far outweighs the data that my practitioner has in their EMR. And so it's been a case of, can I get access to that data? And also, why do you make it so hard for me to get access to my data? I often joke, I tried to change my password on the internet. It only took 6 months because I have like 200 accounts. That's actually an underestimation, right? We need to move to the point where I can use my biometrics to get access to wherever I have my data and be able to pull that without it being a barrier. And wouldn't it be great if I could give that data to my doctor and he trust it, so that he could make use of that in also analyzing my problems? We have to make this more interoperable. We're really still at the start, but hopefully the changes that we're seeing happening is really going to transform this. And I'm sure Kristen will point at this fact that having 27 portals out there is not the answer. And I see what we are really heading for is what I call the data inversion. The question is, who has the most data? And actually, it's not the doctor's EMR. It's more likely my phone. I have my watch. I have my phone. I have things monitoring in the house where I spend a lot of my time. I have so many data points that could be of value. And as we think about how we bend the cost curve, how can we keep us as we age in our homes where we want to be, but be able to tap in and make sure that we are maintaining the health as best we can? And we're reaching this point at this data inversion in that patients will have more of that data and providers will want to tap into that. And I should be able to choose how much of that data I'm giving to health plans, how much data I'm collecting from IoT devices, and what I can share with my provider and have my provider trust me, instead of me having to come in and getting asked, what was your weight reading this morning, and reading it off my phone. Why can't it be a feed? That's where we need to go. We need to recognize that we need to be able to go to where the data is and be able to access that and trust it. Let's move on to the next slide. The other thing I would say with this is there's increasing analysis of whether we can use our phone effectively as our insurance card. There is an implementation guide for a digital insurance card. We have driver's licenses now on your phone. Before long, we'll have passports on our phone. We need our digital insurance card for our health plan on there, and it needs to be the gateway to allowing me to decide what I am going to share with my providers, with my health plans and others. And that will also potentially become the tap into my AI advisor. So I want to be able to connect an AI to my data, to be able to make sense of all this data. What does it mean when I see those readings from the labs that I had at my last doctor's visit? How do I correlate those? When one moves, why does another move in sync with that? I could use an AI advisor to help me make some better understandings and therefore better manage my health. And if you think about it, if CMS was to relax the constraints around digital insurance cards and not requiring the use of a physical card, it could actually be an efficiency gain as well. Let's move on. And so that's it. I'm going to now pass off, I think, to Kristen for you to pick up and carry the torch, Kristen.
Sounds great. Thank you so much, Mark. Well, like Mark gave you a wonderful history of interoperability, I'm going to talk to you about the history of patient access. And why I'm here is in terms of backgrounds, I sit as a board of directors member to an organization called the Caring Alliance, which is a private-public partnership that works on consumer data liberation and transparency to patients and caregivers. This is near and dear to my heart as I am the mom of a child with rare disease. And so my daughter, Bailey, has more than now 30 different patient portals, none of which are accurate, none of which talk to each other. And that is just in the current side of her care, not even historically. So 10 years ago, I founded an organization called Be Well Connected Health. It's actually named for Bailey. I've called her B since the day that she was born, as a way to give all consumers and caregivers access to the information that they need, because in our lives, that information is life-saving. So let's move on and talk a little bit about patient access. Fragmentation in healthcare is very real. It's experienced more by consumers than anyone else. I know that we have a tendency to rely on core operating systems like our EHRs, but the reality is that patient information is now sitting in, on average, for any human, including yourself, more than 70 different disparate locations. And that's because you don't often only have one doctor or one operating system that you deal with. And even though organizations like Epic have done a phenomenal job at trying to bridge together all different kinds of Epic instances together so that doctors can have better visibility and patients can log in now with one universal login, that doesn't cover all of their health. And health care on average for a human is people actually see the doctor on average 2.4 times per year. So all of the interoperability that we're talking about is on an average for our population of only 2.4 events. And so as Mark talked about, when we think about health, we don't just have our doctors, our hospitals, our labs, our pharmacies, our radiologists. We also have vision and hearing and eye exams, but we also have our wearables and our sensors and our life and our goals and our social determinants and all kinds of things that actually make up our health, including even our nutrition. So as we think about health and the more connected data is, consumers are now also demanding a much simpler interface that is personalized, because like every aspect in our digital lives, we typically have a primary app that targets all of something that we might need, like a banking application or a ride application or the ability to book an appointment for dinner. So we tend to choose something that works for us and that is convenient. But in anywhere in America, what patients and caregivers do not have today is a single mobile experience that manages all their healthcare in one place. So moving on to the next slide, let's talk about the history of patient access. So Mark talked to you about interoperability as a whole. This slide specifically talks about all of the rules and regulations that have something to do with patient and patient access. And probably the most transformational, as Mark said, as kind of one of the godfathers of the Medicare Blue Button, which we're very grateful for, was that there was a new technology standard that started to become utilized, and the information blocking and interoperability rules, which came to be after the 21st Century Cures Act, came into play and were the first time in federal history that the technology standard to be utilized was indicated in a federal regulation, and that was open APIs. And what that did was that actually forced us to move into the cloud, which we'll talk about in just a moment. What's the most transformational, and we'll talk about in just a minute, is the new CMS digital health ecosystem, because each one of these regulations, from HIPAA through meaningful use, through patient-facing APIs, all the way to the new technology infrastructure, is that these are really just building blocks on top of each other to get us to not only modernize technology stacks, but also to get more and more information available that's necessary at the point of care and in between care to power personalized and digital experiences. So if we move to the next slide, let's look at the history of patient access. It was not less than a decade ago where the majority of patients with chronic disease or with rare disease were told to carry a binder in their cars to make sure that they had that with them. In fact, when my daughter was hospitalized just 2 years ago, one of her physicians said, Bailey, you're not like others. And I would encourage you to put a binder together, because you having access to your health information anytime you could potentially need to go to a hospital could be life-saving for you. And my daughter laughed and she says, Mom, I really don't think she knows what you do. And so what's great is that we have evolved beyond that, although a lot of folks are still promoting the use of thousands and thousands of patients' records. And so we moved from filling out paper forms into electronic access through portals. And this was incredibly important because for the first time in a digital manner, patients could start to see their information. And then they started to move into, with information blocking rules, patient-facing APIs. And so patient-facing APIs means that every consumer in the US has the right, through any trusted third-party application of their choice, so any app, to access their medical record without any special effort and without charge. And so that allowed organizations like BeWell and others to create apps and onboard as something called trusted third parties, where one by one we would onboard to every provider, every payer, every lab, every pharmacy. And today at BeWell, we can now connect to more than 2.2 million providers, 340 payers, Medicare, the Veterans Administration, as well as pharmacies and labs like Walgreens, LabCorp, and Quest. So for the most part, consumers today, through an application that aggregates information on their behalf with their consent, can pull in the large part of a longitudinal health record instantly. Because we're on FHIR API, that data can actually come in, and we are tracking on average, even for complex patients, in under 2.5 minutes. So we're talking about real-time historical data exchange. And now we're moving into portability. So it's not just enough to have information on our phones, because for the first time, patients are seeing their data and they're realizing that there's errors in their records, and that sometimes when you haven't seen a doctor in more than a year, that you're getting information that is outdated. Those are not currently the medications that are being taken, or you started and stopped those meds. But in FHIR, the way that data comes across is the most recent active information on a patient as of the last time you saw that doc. So think of it as a point in time. Now with portability and the new rules and regulations, we will any patient demonstrated by early next year will be able to have something called a smart health link, or a QR code, where doctors and EHRs who have raised their hand to the pledge will be able to receive a full FHIR US Core V3 medical record on behalf of the patient. And you might be thinking, wow, that's a lot of data. And if you saw my daughter's data, yes, it is. But that information coming in at the point of care can be used to help facilitate a movement that we like to call kill the clipboard. So at a minimum, the things that stay stagnant about us are family medical history, historical medications, diagnostics, procedures that we had years ago. Being able to port that using a QR code to fill out the forms at the doctor's office that we expect that our doctors know about us, that they've received about us every single time that we've seen them, but yet we fill out that form every year anyway, that those pieces of information will transmit directly into the EHR at the point of care, and that within 24 hours on the way out of a doctor's appointment, we will now be able to receive our comprehensive care record from that visit to add to the longitudinal record, all using FHIR. So as you can see, it's only been about a decade, and we have actually moved pretty far in that timeline. Now, is it far enough for patients? They would tell you absolutely not, but it is certainly progress. So let's move to the next slide. So as we think about data and data exchange, most from the physician perspective, think about things like, well, wait a minute, we have national networks. We have Commonwealth and Care Quality and eHealth Exchange, or my EHR system has things like Care Everywhere that bring data in. It's important to know that while that data from a regional perspective might look comprehensive, is that it is nowhere near comprehensive. There are 2,000 EHR systems in our country today, and only a small percentage of them are actually what is known as required to comply with meaningful use. And so when we think about things like hospice and SNF and home health and vision and dental and eye, those EHRs are not yet transacting in data under a required mechanism on either our national exchanges, our regional HIEs, or through organizations like Epic and Care Everywhere. In fact, EHRs often don't share information with one another. So the reason that it's become so important to create things like TEFCA, which came out and was launched and deployed in December of last year, is that it held the great promise of a single on-ramp to nationwide interoperability. However, it's voluntary. So we know that it is not going to be 100% coverage of every doctor in the country. It's not going to be representative of every payer. And so all data is not flowing through any one of these networks. And so there's a new concept for patients coming about that we call a network of networks, where organizations like Be Well and many others like us have the ability to go out and we can connect to the national networks, we can connect through TEPCO, we can connect to the patient-facing APIs, which are the only mandatory patient-facing required interoperability mandate today, and now CMS-aligned networks. And so we'll talk a little bit about what that means on the next slide. But pretty much we can get to nationwide coverage using a network of networks rather than just relying on one singular location for data exchange. And that is becoming critical to patients and their families. So let's move on to the next slide. One of the most important concepts for you all to understand, because you might think, well, my portal gives my patient everything that they might need. Did you know that 75% of patients who want access to their information actually abandon at the step of logging in? This is really important because the other concept about portals that breaks down when we think about a longitudinal health record is the fact that there are use cases that a portal just simply cannot support. And that's because of how HIPAA grew up in our country and the protection mechanism. So my daughter, Bailey, has just become an adult. She is now 22 years old. And in order for her to gain access to her longitudinal record using a portal account, she would have to have an active portal account with a login and a password. The challenge is when she identifies that she has data from when she was in pediatrics, that she would need to call to get an account with a login and password. And the first thing that she's asked is, do you have an upcoming appointment? Are you a patient? And if the answer to that is no, she couldn't even generate an appointment because she is no longer going to see a pediatrician. She's not going to be able to access her information through portals. So we cannot keep using portals as a gating factor. One, because it is too hard to refresh tokens on a portal for someone like my daughter with more than 30 different portals that need to remain active in order for her to get her current longitudinal medical record, let alone bring her historical data with her. And so we are now moving into an age of what Mark already mentioned of modernized digital identity. So let's go to the next slide. I like to deem what we are trying to do portalitis. This is something that we've been coined with over the last decade, but this is a little bit of fun for you all. Portalitis is the diagnosis that I think we can eradicate in our lifetimes. And the way that we're going to do that is through using modern identity, which is actually more private and more secure than using a portal and password. Portalitis is actually quite fun because for those of you who understand that most people with complicated conditions and or rare disease have caregivers in their lives. And 80% of healthcare decisions in our country today are made by women. So most of the time, my daughter's doctors don't know whether it's myself or my daughter that is corresponding with them through the portal. So as you can imagine, without the right paperwork in place, right, this would be considered technically a breach. But this happens all the time because caregivers will do what they need to care for the people that they love. So when we move to the next slide, we will talk about what identity looks like then versus now. And this is an important concept because through HIPAA, the way that people gain their access to information today is that they show up at a doctor's office in person. And the first thing that they're asked for at the desk when they're checking in is driver's license and insurance card. Well, let's just pretend that every front desk office staff was trained like a TSA agent. Their job is to make sure that you look like the picture on your ID and that the information on the ID matches the information on the insurance, and that is how they verify you to give you a credential to a digital portal. But more and more often, the way that we're accessing physicians is digital and virtual first, and that means that we can't show up in person. And so now we need a new way to identify people's privacy and security. And so I always like to say, if you can use your face to board an airplane, you should be able to use your face to collect your medical record. So if we go to the next slide, the concepts of modern digital identity is that there are Kintaris certified vendors, and this is important, organizations like Clear or ID.me, where they can not only scan a government issued ID like the driver's license, just like you do in the doctor's office, but they can actually verify it back with the DMV instantly. but being able to capture a live selfie and a biometric match to make sure that you are, in fact, who you say you are. And they can confirm that information about the device you're using belongs to you, like the metadata on a computer or a phone. And they can validate with issuing authorities like the Passport Association. So we now have much better confidence with IAL2 identity that someone is, in fact, who they say they are behind a digital device. Let's move to the next slide. So when we think about the ability to pull in a longitudinal health record, we are actually now at the stage, and we demonstrated this live on TEFCA at the most recent HIMSS and HLTH conferences. You can use your face in order to verify your digital identity. We can do something called record location services on the TEFCA national network where people participate. Most patients don't remember the names of every doctor that they ever saw. So now we can tell them where your demographic information matches physician records where we believe through patient match services that they have information on you. And patients can now decide to bring in information from every doctor that's presented to them, including those they may have forgotten that they saw at one point in their lives. That information can be used to be brought in across all EHR instances, normalized under a semantic interoperability layer, and then shown trend lines and graphs and things that they can see across their entire longitudinal health, and be able to be given information on how to simplify or understand and interpret that information. And I don't mean diagnostics, but I mean more of a co-pilot in your hand. And this is important because if you talk to any of the foundational LLM models, they will tell you that consistently between 15 and 30% of all queries to date using AI are health-related queries or interpretation of results for labs and images. So patients are already using this technology, and so it's important that as a healthcare delivery system that we embrace it to make sure that we can give accurate and well-trained information that does not hallucinate and does not diagnose, to be able to give patients their information because they're already doing it. Next slide, please. So as we think about the new CMS-aligned networks, which were just announced and that are going to have a number of different participants be able to demonstrate this new floor of technology live by the end of this year. The most important things to know about it are that, one, patients are not required to use portal credentials or even have a portal account in order to access their information. That they will be provided record location services so that we can help them identify where their data is, where they may not already remember. That it will use FHIR, the Fast Healthcare Interoperability Resource, as the floor, not CCD, not HL7, but FHIR. And that it must meet the floor today of US Core v3. And this is important for a reason that we'll talk about in 1 minute. But also that we're going to go beyond what has been transparent to patients before. And everyone who participates in this new model must be able to not only track and store each time a patient's information was accessed, who it was for what permitted use case, but they must actually show that to a patient in real time. So patients will have visibility into all times that their data and information are shared. And we have to go beyond US Core v3 to show them upcoming appointments and other encounters that are not mandatory, but these organizations volunteered to say, we will share this information back to patients. Next slide. So Mark showed you this slide, and I'm going to talk about it from the perspective of the patient. The reason that this matters is that we are getting closer and closer to a full electronic health information export, or EHI export. That means both standardized and unstructured data. So for the first time with US Core v3, which is the floor, you can see images and you can see reports and you can get document attachments, but also unstructured data, progress notes, clinical notes, my care plan from my physician. Imagine an entire army of trusted third-party apps with patient consent who can pull in the care plans that you prescribed to your patients and who can help successfully educate and nudge them to follow those care plans in between doctor visits. So US Core v3 expands data to a point where it is actually useful for a patient for the purpose of personalization. Next slide, please. These are the first 60 organizations that took the pledge to be live in 2025. Some of the things that you will notice is every QHIN and TEFCA put their hand up to be a CMS-aligned network, as well as new organizations who have not been networks before, like Innovaccer, Datavant, BeWell, and many others. but also health systems and providers, conversational AI apps, big payers have combined. So, and then you think about the big technology companies, Samsung, Google, Apple, they're all here. And they're saying it is time for us to provide personalized healthcare at scale, direct to patients, and this is a must-share model. Next slide, please. So we are now at the point of portability, and that means that patients will be able to facilitate their mediated medical record to providers at the point of care, and they will be able to receive their information back in an instant transaction. And that's very exciting to patients and caregivers. I know it is for myself and for Bailey. Next slide, please. If you have any questions, obviously feel free to reach out. There's certainly a number of questions that might come to play. There are also a number of blog posts we can point you to around privacy and security and trust over third-party apps and who oversees and regulates them. So if any of that can be useful, please don't hesitate to reach out. We're happy to point you, and you can always find things at the Caring Alliance website as well. Thanks for having me.
Thank you so much, Kristen. Next, we're happy to welcome Mr. Hayes Abrams, who's Executive Director of Enterprise Healthcare Management at Healthcare Services Corporation. Welcome, Hayes.
Hi. Thank you very much. Thank you, Mark and Kristen. Very informative discussion, and I really appreciate your journey. Likewise, I've been in the industry for a little over 3 decades. I've held roles in many data exchange opportunities, admin side, clearinghouse, and then ultimately moved more into the clinical space. And I work for one of the big blues. It's called Healthcare Service Corporation, Blue Cross Blue Shield of Illinois, Texas, Montana, New Mexico, and Oklahoma. And I support and execute against our health data exchange strategies here. I will be stressing a little bit more, if you could, next slide, please, Amy, a little bit more on the data. Yes, I can tell a story of depth and breadth, and I can tell a story of economic value realization. I chose to take a little bit more of a tact in hearing so many decades of providers concerned about insights not being actually correct from the health plan and how to get them into the workflow, which we are doing with providers, but how to build those data silos today and reduce what I perceive as actually far fewer care gaps in the industry. It's more of a data silo gap. So I've spent a better chunk of the last decade building similar data bridges, as Mark and Kristen had stressed, to get that sort of coast to coast data access so that we can have the best insight. So when we do give a care gap insight or other things to a provider or a member / a provider's patient, we're giving the best we can, in today's state and in year insights. So I appreciate the journeys that everybody's on. I've been on them as well, but this is a little bit more of a lean towards how do we get the best data in now to help people who need the care today. So we get a lot of data, big health plan, we bring it in, put it through all of our big infrastructure, but really this is a presentation on the impacts that's having on certain areas of care. Next slide, please. So we see potential sources of value, definitely reduce latency from health data, expanding on what we do today in our existing sort of domains of care, that we're able to use the electronic health records to eke out more insights in today's use cases. And then we've got more and more insights that we can provide today, whether it's sourced from vitals, clinical notes, et cetera. We're really changing sort of in-year behaviors of a health plan to provide better insights at the data type of deliveries we give today. Nice. Next slide, please. Clinical data is faster, right? Faster than claims. So the legacy X12 world of health plans, looking at claims, you could be days, if not weeks, if not months or quarters behind in, taking the data and turning it into an insight. And we've seen that our health data is anywhere from hours, if not a day or so, from source to target here at Blue. And that, of course, now brings a whole bunch of insights that we can do differently than we have always done with claims. So health data first is obviously the way to go for us. Next slide, please. So expanding existing data. So yes, there's some redundancy in what you get in the clinical data versus claims, but we're seeing more and more insights of, this is some pregnancy-related condition codes. So we're saying an additional match with information from the clinical versus the claim for pregnancy-related codes. And again, it's not all net new, but it's definitely bigger, faster, stronger, And we get a better sense of historical information that you generally do not get in claims today. So next slide, please. Maybe not lost on the clinicians in the world, but definitely in health plans, the new discovery, more discovery by having novel domains. So vitals that we traditionally never got, physical information and observations that we had never seen, the behavioral health data that's expanding our SDOH opportunities and social needs. And then obviously just the problem list and medical history. We get so much more insights and discharge instructions that is providing a tome of data that we can go mine against to help in our care management programs and member outreach, as well as the clinical gaps in care delivery we do with clinicians today. Next slide, please. So on maternity, our problem was we were trying to figure out where our pregnant members were before we even knew they had a need, and what was our ability to outreach to our members. And so how could we use the health data? So EHR data, the labs, even ADT information can tell you when someone's scheduling a C-section 7 months from today. So you can say, oh, I know that member is possibly pregnant. So maternity risk was a great place for us to focus on a current domain state. Next slide, please. So what we were able to do is find 2% more of our members who, if we tapped into the LOINC code and obviously CP2, ICD-10, but we found by tapping into the claim alone, we were missing 6,400 members who actually had in the maternity risk bucket. That's 2% of our pregnant population, which is a huge impact. And that ties to pregnancy risk as well as anything to do with postpartum outreach. So big uplift for us. We're very excited that we can now make outreach to these extra 2% of the members, as well as put information in their clinician's workflow to inform them that there is potentially either pregnancy, good thing, or postpartum issues. So we'd like to cut that off. And we have put this into our risk programs and into the information that goes out to the providers today. Next slide, please. Obesity reporting, underwhelmed with their ability to report to the state. I use the example, state of Illinois. We had the state of Illinois tell us that, or we told the state of Illinois that our patient member population was only 12% obese in Illinois, and the state of Illinois laughed at us and said, you're actually going to be closer to 40. If you go to the next slide. Well, they were right. And we tapped into the BMI information in the EMR records, and we were able to identify an additional 16% more members who had obesity. I think we tapped out right around the 39 percentile of our member population in Illinois that was obese. So just generally, folks in the past, I've been doing this a long time, saying we're going to deliver gaps in care to providers or patients. We would have been off a heck of a lot with obesity reporting if we weren't tapping into the data infrastructure that we've built. Next slide, please. So where can we go with that? Additional maternity risk models, obesity models, better supporting that holistic care that Kristen talked about. And when people do tap into the patient facing API or payer to payer or payer to provider information, our data stores will be filled with more insights. Kristen talked about data, insights, and information and insights. We will have better insights to deliver into the types of exchanges that they stressed. So next slide, please. I'll pause there. And next to Amy.
Yeah, thanks, Hayes. Thanks for having me. I'm Amy Parekh. I am our Chief Health Officer at Included Health. I think we can move to the next slide. Next slide. So just really quickly, I will come to this maybe from a different angle than the previous speakers. I come to this not as a technologist or a data expert. I come to this as a provider who takes care of a lot of patients who want better healthcare. And what we have focused on is how do we use data to actually improve the outcomes our patients or Americans generally need in their health and that they deserve. So it's really how do we leverage the data to show up for the patients in a way that they can make their own healthcare better, and to show up to the providers in a way that they can make their own healthcare better. I'll switch to the next slide. A little bit about included health, because it might be a type of entity that many of you don't know much about. We provide personalized all-in-one healthcare. So we are trying to be that place where members can come, whether they need help with their mind, body, or wallet. A lot of what happens in healthcare is clinical. That's a place I sit very comfortably. They want to know what's the next best action that they need to take for their health. But a lot of healthcare is honestly about the money. It's about what's the bill that I have to pay? Do I actually have to pay it? Is it too much? Is it going to bankrupt me? Or it's about the mental stress, the administrative burden that we put people through as they manage through the course of their healthcare. So it included, we're trying to bring all of that together, that mind, body, and wallet. And as a clinic, we provide primary care across all 50 states, as well as urgent care and behavioral health for all ages. We also do expert medical opinions. So if you're in any part of this country and want to get an expert medical opinion to make sure you're on the right course for your diagnosis or treatment plan, we'll make sure you get that expertise. So that's who we are as an entity. You might wonder, who do we serve? Next slide. We serve mostly folks who are self-insured. So folks who bear the cost burden of taking care of large populations. We also serve health plans as their virtual provider, again, across all 50 states. And we do this for now about 12 million Americans. Next slide. So a little bit about data. So data for data's sake, we don't think actually makes healthcare better. What makes healthcare better is when data, enabled with technology and a user platform that people can use easily, whether you're a Medicare patient, whether you're a Medicaid patient, whether you're a commercially insured patient, it actually has to work for you, combined with humans who can help guide you in understanding that data, understanding what to do with that data. That's where the magic happens. Really, that integration is the innovation. One without the other isn't really that helpful. And before I go to the next slide, I'm actually going to go off script a little bit. And I was actually on a plane this weekend and had to be the emergency doctor for a patient who was sick, or a person who was sick on the plane. And I was so thankful because this patient actually had a piece of paper that explained all of their medical problems in a half a page. That's what you need. You don't need reams and reams and reams of data if you're having to make a decision for yourself, your loved one, or your patient. You need the insight. You need it to be synthesized. You need to be able to make quick decisions based on that data. And that's sort of the next level we're trying to get to. Next slide. So how do we do this at Included? We purchase large amounts of data from commercial clearinghouses. This is mostly commercial data. It's all the claims data, but also includes some Medicare data. We also get data from our clients who, again, are trying to improve the health of the populations that they serve. We bring in other data, whether that's data from the patient directly as they interact with our app or they answer our questions. We bring in sanctions data from across all 50 states. We bring in board certification data. And so all of this goes into what we say is power. But again, that data in and of itself isn't actually that helpful. What's helpful is how it shows up to the member. Next slide. So what's one example of how this can show up to a member to actually drive better outcomes? We've taken all the data and at the NPI level, and regardless of the specialty, assessed a number of quality measures. And again, maybe you're the patient who can go up and look up every single quality measure by the provider in a sort of search. But honestly, what you want to know is, who should I see right now? And so we take that data, we match it to you so that if two people are looking for the same doctor in the same specialty in the same city, they actually don't get the same list because turns out they're different people. And we match it to you in a way that's very user-friendly so that you can just quickly scan, who should I see, and go on your way and make that appointment. That allows people to actually get better outcomes and actually decrease the total cost of care. Because turns out when you're seeing the best match provider for you, you're going to get on the right path quickly. Next slide. This is different than most places, because most places, again, you can just go into a provider directory and look for a neurologist. But you might not need a general neurologist. You might need somebody who's focused on stroke, or you might need someone who's focused on Parkinson's or on multiple sclerosis. Those three are not created equal, and it's important for whoever's providing you with the information to understand what your needs are so that they can best match you, and that's where we come in. Next slide. I'm going to transition from how we use large data sets to drive real outcomes to actually something more basic, using patient-reported outcomes. Because again, ultimately, you can have all the data in the world, and we're not going to become healthier as a population. What we're focused on is how do we actually make people healthier, leveraging data. And some of that data comes from the patient themselves. We've talked a lot about patient-reported outcomes in healthcare, at least for the 25 years I've been trying to make healthcare better for people. But we all know we haven't really succeeded. And part of it is because we're not asking members the questions they need to be asked in timely ways where they can see the value that they themselves will derive from that information. So what do? We started asking our members, very easy in the app through a text message, in the last 30 days, how many days has your health not been great due to mental or physical reasons? It's a CDC validated measure. And we took that, we measured it, we intervened on those patients who had a lot of unhealthy days, and we made it better. And the patients know that their healthy days are getting better. Turns out this also links to reducing total cost of care over time. It's patient-centered, it's predictive, it's intervenable. That's how data can make a difference. Next slide. And then how does this all come together? It comes together because we can use data to engage members at the right time. We can present them with the types of interventions that might actually make their healthcare journey better. And we can re-engage them when it's time to do the next action, whether that's getting a mammogram, a colonoscopy, going to the next type of specialist if they're complex. And that all builds trust and actually delivers healthcare outcomes over time. Next slide. Where do we need help to continue to make data actually drive outcomes in healthcare? You know, I think there's still confusion about who owns the data. In my opinion, the patient owns the data. You could argue health systems sometimes think they own the data because they have the labs that are generating it. Some people think health plans own the claims data because they might be doing things with it and generating insight based on those claims. But ultimately, every person owns their own data, whether that's because somebody paid for the intervention, whether that's because somebody did the intervention. But we actually need to align on that, because not aligning on it allows people to keep the data in silos. As we want to move towards data leading to better outcomes, we have to think about patient-reported outcomes, but we need standardization. What are the patient-reported outcomes that we should all be measuring? How should we be measuring them so that we can actually decide what makes healthcare better and what isn't actually making healthcare for people better? And then entity resolution. I know we've already heard a little bit about that, but really trying to make sure that we know exactly for whom what is happening. There continues to be inconsistencies there throughout. So with that, I think I'm done. Of course, open for questions or comments as we move to the next section.
Thank you so much for that, Amy, and thank you for all of those great presentations that were truly thought-provoking. We're going to move on to a time of committee questions. We've got about 30 minutes, looks like, which is fantastic. This time, I'll ask PTAC members, please flip your name tent up. And for our virtual committee members, please raise your hands, and Amy will help me keep track of the questions online. In the interest of ensuring balance across different perspectives of questions, encourage experts to keep each response to a few minutes, and then certainly feel free for questions often be pointed to one or two panelists, but then feel free to pass it among the group as you have perspectives. So let me start with Jay.
That was a great presentation. Thank you. This is for everybody. From your perspectives, what's the major barrier to the interoperability that we've been dealing with for the last 25 years? Whoever wants to go first, feel free to jump in.
I will. I'll go ahead and join. There have been a couple of challenges. One is that as we move to digitize records through meaningful use, is that we made a core mistake by allowing thousands and thousands of entities to create their own proprietary data models in that digitization. And we've now had to find a way to standardize that in order to share information across all of those proprietary data models. But I also think that it's important to understand the elephant in the room, which is that there are a lot of entities in healthcare who make a lot of money on data and data selling and data sharing. And there are a lot of challenges from a competition standpoint when you make it easy to port data from one system to another, because you've effectively taken away switching costs between technology vendors. And so there are a lot of folks who have tried very hard to make it difficult to extract information from a core system of record. And I think that time has now passed. And I think that's why you're seeing so much optimism from the community, because we'll be able to make a lot more progress moving forward now that we've created standards, we've created technology, and we've created the incentives. And quite frankly, the market pressure for folks to start competing on top of the data versus on the data itself.
Hear, hear. Quest for relevancy and focusing too much on the how, not the what.
Yeah, I'd agree. The other issue you have, I think, has been the fact that people have been driven by compliance, and to date, it's largely been what's the minimum I need to do to tick the box. And I think as we look at particularly the prior authorization API regulations, it's probably one of the first real regulations that has the opportunity to be business transformative. We're seeing a lot of payers that are saying, okay, I've got to do this for my regulated plans, but what's it going to take to do this across my entire member base? And that is really, I think, where we've got to go. And I agree about we've got to get past this state where people are making money off just simply connecting to actually looking at how you add value to the data and really deliver results.
Yeah, I would plus one what everyone said. It has felt like interoperability has been a compliance issue, not a way to actually make healthcare better for people. I guess one proposal I would make is that instead of trying to solve the interoperability problem, we try to solve actual use case problems that patients feel, and really try to figure out what are the data pieces that we would need to solve that problem for the person, and tackle it from that approach versus we need everything all the time, all at once. That would be a very different approach to the one that's being taken.
Outstanding. Thank you. I've got Krista, then Walter, and then myself, if no one else. Krishna.
Yeah, excellent job, team. Great perspectives from each of your domains there. Yeah, loved it. So mine was sort of another barrier follow-up, and Amy, both you and Kristen mentioned sort of the consumer owning the data, and obviously we've had, I don't know, over the decades, many sort of failed attempts at the sort of personal health records by many big names in technology too. Kristen, I guess maybe directed at you. You've had sounds like pretty good success in clearly like connecting with providers and payers and really having the consumer be the part of the access and the control there. I guess if you were to unlock more value or more scale, like what do you spend thinking about sort of resolving from a barrier perspective? So more barrier, but more fine-tuned on the consumer. Like what's the next unlock for you? I guess I'd love to learn.
Absolutely. So first and foremost, I think we've accomplished two great barriers in the past. One is just giving patients access free of charge through an API to their data. The second, which was just announced, is the eradication of portalitis, which is the biggest barrier to people being able to access their information in the workflows today. And the next, I believe, war to be won is in unlocking the APIs for access. Because it is not enough to help patients understand their information and give them insights about it and tell them what they need to do. You need to make it easy to do it. So one of the recommendations that we've made to the administration through the CMS RFI response and others is to move the meaningful use certification off of the EHR workflows itself and onto the API stacks that surround the EHRs. And what that does is it allows for standards to emerge around things like scheduling and messaging and RX refills. And it allows patients access. So when we're encouraging them to follow their care plans, that we can make it easy for them to do those things. And today that's very difficult because those APIs are sitting in a category we call proprietary. And oftentimes they are provided only to an EHR or a payer's first party product versus the broader innovation ecosystem, where I think you could see a lot of value emerge very quickly.
That's great. Thank you.
Walter.
So, Krishna actually asked my question in a way because I think the promise of an interoperable patient-controlled longitudinal health record has been around for, I don't know, like 15, 20 years. I remember the days of Google Health and Microsoft Health Vault. Those efforts kind of failed because of lack of user adoption, patient engagement. And I've always kind of thought a large part of this was, in part, a technology problem, but so much more than that, because patients often just weren't activated or engaged or cared enough, it seemed, to really do the work to understand their health conditions and make decisions from their health records that would impact their care. So I guess maybe a different spin on Krishna's question would be, what would really be the motivating factor now that's different from before to activate patients to really engage with this longitudinal health record that hopefully they'll control? And if, since we are focused on payment models, if there are any payment model suggestions, we would really appreciate those.
I'll start on the access part. I think Mark will probably join right in. The reason that those earlier attempts at the longitudinal record failed is we made it too difficult for people. Until we started publishing data showing that for everyone who showed the intent of wanting to collect their longitudinal data and keep it on their phone, that 75% of them drop off the minute you ask them to log into an account because they don't have or remember their portal credentials for something that they might have accessed one time. It wasn't for a lack of people wanting, although that was how I would say the PR was spun. There are a lot of people who want engagement where it's just simply too difficult. In the same way, and I'll from a physician perspective, why I think access is the war to be won, we do scheduling for one of the health systems in the country. And one of the things that we learned was that, one, the more access you open up, the more people will take those appointments because what they want is they want care and they want it quickly. However, there are a lot of physicians and specialties who still have not opened up their schedules to online and mobile scheduling, even where it's possible to connect to a patient. But some of the more interesting stats are that most net new patient acquisition comes in after hours when the call centers are closed. So for people who have online and digital booking, they actually get more appointments filled in the evening hours because people work. And then when they say, hey, listen, we built up all this capacity for things like telehealth during COVID, but we're only getting about 30% of our appointments booked. We're thinking about tearing down this infrastructure. And I said, well, wait a minute. Give me a shot at putting it as part of the scheduling workflow. So when we say, hey, if your doc's not available to see you, here's the next available doc who is, or based on what you're searching for using natural language, looks like we could treat you through telehealth today. Would you need care sooner? 100% of those appointment slots are booked from that point forward for 2.5 years, and now expanding the capacity needs. Because what we've failed to do is give people the easy button to get the job done. And when we do, they will comply. So I actually believe that we are at the point where you will see a tremendous amount of adoption, proving things wrong once we eliminate the requirement of having to go through a portal or a portal rule set in order for patients to access what they need. And if you think about even scheduling, the number one thing we ask people to do is start with the specialty that they need. If you think about and compare the health literacy of America with the fact that they need to search for an otolaryngologist or know how to spell it or even know what it is, we've already broken down the pathway for them to access care in step one.
Let me add another perspective, since, Walter, you asked about relation to payment models. We've done some great things in terms of requiring APIs to be made available to these consumer health apps for free. It still requires investment. And one of the challenges I think we have is this perverse payment model where I, as a patient, am not the customer because it's maybe my health plan that is paying a large part of the bill. And I feel that it ought to be possible for me to be able to subscribe to the consumer app of my choice and effectively either offset that against my taxes or against my health plan so that I'm actually the customer and not my health plan or my provider, so that I can choose the apps that work for me. It's not to try being force-fed to say you have to use this app because the health plan offers this. It's, if you look at everybody's smartphone today, I'll bet you my front screen doesn't look anything like yours. Everyone has a personalized requirement, and let you choose the apps that really work for you and be able to pay a subscription fee that is offset in some way. And that way we can probably really provide a business model for these consumer health apps to really take off.
I think one thing I would build on that Kristen started, I think, Mark, you're building on this, is exposing data needs to be linked to solving somebody's problem. And so I think scheduling is an interesting example of this. What is the problem people face? They can't get in to see their doctor. They're dealing with a bill they can't handle. They don't know if they're taking the right meds. When you ask people to see all their healthcare data, but you can't actually solve a problem for them by exposing that data to them, they have no need to engage with their data. Now, one of the things I joke about, because I love being a doctor, but most people don't wake up in the morning wanting to see me. If they did, we'd be pretty messed up as a society. Most people wake up trying to, and I did this morning, trying to get their kids to school, trying to get to their job, trying to make sure their car is running, you know, all of the things that should occupy a productive human's mind. They are not trying to engage in healthcare. They come to healthcare when they need us. And so trying to put data in front of people without solving their problem isn't going to get people engaged in their data. So it really does have to be linked. And I think that could be a big unlock. How we think about payment models with this, you know, I think Mark has an interesting idea about really making the person the customer. I think the trend towards high deductible health plans sort of starts to do that. But it hasn't worked because then you're just sort of threatening bad financial outcomes with healthcare versus good financial outcomes, which is, I think, a place where you were starting to lean to. But I do think the transition to value-based care helps with this. Because if the provider is actually aligned with the patient, you should actually be able to use this data in a way that can then actually solve the problem for the patient.
Yeah, just a quick follow-up. I mean, I appreciate that because I guess I'm personally skeptical that access is the main barrier in this day and age of, you know, we access everything through like two-factor authentication, our bank accounts, our email accounts. I think this idea that Kaushik actually presented in his presentation earlier on, that patients often like most patients rely on their providers to help them understand their health information and what they should do. It makes that provider, I guess leveraging the provider input through this increased patient access really important. So I appreciate that.
Okay, I'm going to skip myself for now, go to Larry.
Thanks, Lee. I enjoyed all four of the presentations and compiled a lot of notes here, but something that really stuck out for me was Hayes's example of obesity. How extracting the diagnosis of obesity from claims failed miserably. But having a BMI, having a structured data input that could be queried, all of a sudden fixed the problem. The subject of this session has to do with infrastructure of our data. How do we improve it so that it can be help patients empower their futures? And so, I'm sure you all have gone through data analysis with claims and seen all these non-specific ICD-10 codes that physicians use because it just happens to be the next one that shows up on their drop down for the illness they're seeing, or maybe they code the reason the patient came in for the visit, the symptom, rather than the fact that they have inflammatory bowel disease. And it becomes, the problem we have is one of the problems we have is this: there's no financial incentive for a physician to code to a complex level. And we are faced with a lot of garbage in, garbage out. And we may be able to transfer it between each other and open up all these pathways, but unless we fix the quality of the original data, we're not going to get to where we want to get to. So my question is, what are you all doing to improve the quality of the structured data that becomes part of the medical record?
Yeah, go ahead, Hayes.
Yeah, part of my role, I work with a lot of the EMR companies and the providers, all from the federated to the SaaS models. Big champion of what we call mapping for measures. And you've seen one provider's office, you've seen one provider's office. And we spend, a great example here with Northwestern, we sit down with them and have them take it through their value-based care committee where they can actually better structure and transfer data to us. So capture, structure, and transfer, because there's a lot of data that's non-transferable that comes across. So yeah, so Epic now calls it mapping for measures too, but we spend a lot of time sitting down with the providers so that about payment, when we sit around at the joint operating committees and say, hey, my score is X or my score is Y, we're not in a debate. So we can see as much data shared as possible. So we do a lot of activity. It's pots and pans. It's a lot of work. You also see a lot of the SaaS-based EMRs or even the hybrid ones have a lot of restrictions about what they can and cannot capture and share. Behavioral health is a great example there. So it's really about getting into that old clearinghouse model of you've seen one provider's office, you've seen one provider's office. And I don't think FHIR is going to solve it because it's all the way, further up the stream than the modality of transmission. It's really about workflow and data capture.
So I've got 2 points on this. One is that organizations like ours that consolidate data from across the entire ecosystem must have a semantic interoperability layer. I mean, even things that are very simple, such as some EHRs report in metric units, some report in imperial units, some mandate NDC, but leave RX norm blank. There are a lot of enrichment activities that have to happen from a data perspective to make it more complete and more accurate, just in the data that transacts today. And Hayes is right. Even in FHIR, we are a co-development partner with NCQA and CMS on their digital quality measures, trying to move things to be able to be more automated. And we might see that while the definition of FHIR has, mammographies reported in these 2 resources, that we'll see it show up in a 3rd and a 4th resource. So we have to go find it and move it in order to make it work for structured analytics. But the point that I really like, and there's a new framework that has come out called PIQI, P-I-Q-I. And I think that you should take a look at that. It is the ability for companies who transact in data to report almost a quality scorecard back to providers and payers based on the quality of their data, not just the completeness of their data. And so PICI is something that I think you're going to start seeing widely adopted in the industry from a digitized standpoint. But as a mom of a child with rare disease, the thing that I would leave you with is that no matter how much we clean and structure and train to the data, is that we are in a world where the science of medicine has far surpassed the administration of healthcare. And I have a child with a rare disease that is unnamed, that is N of 1. So as she, of course, needs to be billed for as a multi-million-dollar patient, my daughter requires $550,000 worth of medications to stay alive every year. She is 22 years old. We actually offshore one of her medications to save $250,000 on the same brand name drug from the same manufacturer, just imported from another country. With her, my biggest fear as a parent is not that doctors will not be able to treat her and keep her alive. It's that she's going to have to at some point change insurance because she is on an off-label use of a medication that is prescribed only for 3 types of blood cancer, but she's never had blood cancer. And because her diagnosis is not named, there's no protocols for it. So all the diagnoses that she does have in her chart would show up as a red flag for any prior authorization for an experimental use of a medication. So until we get better about looking at prior trends for episodic care, and anybody who looked at my daughter's record historically would say, oh, wow, she was uncontrolled for this period of time where she was hospitalized for a year. She was a multi-million-dollar patient. She has been controlled on these medications with perfect labs for 2 years. But the minute she switches insurance, they're going to flag her medication and make her go through all the different things where we failed peer review over and over and over again. So I really think we need to start thinking differently about how we look at care as a whole and unique to an individual, because we finally now unlocked the data to allow that to be possible. And I don't think that we have looked, I think right now we're doing a lot of digitizing manual processes that were built for a different day and time than today. And no amount of data quality is going to fix that problem right now.
Yeah, great answer. I'm going to pitch it to myself and go down. Kristen, this is mainly for you, but others will have comments. So I was really struck by the comments around moving to a federated identity model and trying to break a portalitis. I have the pleasure of using ID.me as a veteran accessing VA, Department of VA, and other military records, and it works seamlessly every time, and it's simple, though hard to set up. So unpack that a little bit for us. When and how do you see federated identity really moving out into practice? Are there any, EHR companies are starting to use it for their portals? When would most consumers start seeing this concept move into their realm of healthcare?
Yeah, I think the exciting part of this is that it's happening now. Third-party applications are already using IAL2 technologies for identity verification. Many health systems are using this to check in. It also, in addition to it being a better identity pathway for individuals, it also creates a lot of downstream, it creates solutions to downstream problems that health systems have. By using identity at check-in, you're not keying in what people are writing and making mistakes, creating duplications. One health system actually reduced the duplicates in their health records system by over 90% once they instituted IAL2 technologies, which of course impacts revenue cycle management and their ability to collect a bill. So based on CLEAR, I would say right now is overwhelmingly becoming adopted by health systems and by payers. ID.me is probably the second. ID.me is more on the federal side. CLEAR is more on the commercial side. But knowing all of the health systems and the payers that are adopting, I would say inside a year, you are going to see IAL2 tokens be the predominant method for creating accounts and for sharing of accounts and for recovery accounts, not just on the patient side, but providers as well, and hospital staff, because a lot of health systems are doing this also to credential the people that are coming into work, which solves a lot of problems in their workday and patient management flow, and making sure that providers are in fact credentialed, not sanctioned. So it solves a lot of problems, but it's being widely installed right now. And I would say it would be the primary method of account creation in under a year.
I'd add to what you're saying, Kristen. At Onyx, we implemented patient access for a number of Medicaid state agencies, and they had the problem that they don't have a member portal in many cases. And so we actually worked with ID.me. So ID.me provided the identity verification and created that digital account. And then we were able to match that to the data that the state was giving us. And it really simplified that, because in many cases, those states are also using ID.me, for example, for things like employment verification when people are going to Department of Labor. So it has, the technology is there, the technology is implementable. It's all standard APIs to integrate with.
And it's also like a 3-step process for patients. Like, it's the first time setup where you need document ID. And the more that we see adoption of the mobile driver's license and more states who adopt the mobile driver's license, the biggest friction point in the setup goes away. Because you're not having to actually go find your purse, find your wallet, dig out your ID, harder for females than males, and take a photo of it. So when the mobile driver's license continues to get adopted at higher standards, even IAL2 verification and setup becomes much simpler, but you can do it. Even the average Medicare beneficiary can set up their identity in under a minute and a half. So it's a pretty frictionless experience.
Okay, and last question to Krishna.
Yeah, thanks, Lee. Yeah, excellent comments on identity management, Kristen. I'm excited to see it sort of expand, because I think that's definitely a barrier we have to overcome from a consumer perspective. Mine's more, maybe the question's pretty more for maybe Hayes and Amy there, but obviously you're all welcome to answer as well. So particularly from, I mean, Hayes, wonderful to see the sort of what we've had to do to bridge the sort of clinical data divide in the payer, and sort of what you and team have been able to do, particularly in obesity or blood pressure, other elements there as well. I guess from a purchaser and a payer perspective, so given Amy, you represent some of the sort of purchasers or self-insured ones, and then Hayes from your broad lines of business there. Information blocking, I'd love perspectives on that. Like, how are you all overcoming that? I mean, Hayes, when you and I worked together, clearly it was a lot of value-based care incentive and just brute force, conversations, the pots and pans, as you would call it, going from provider to provider and being like, let's talk, and how do we bridge the divide? But I'm curious on, as you both are seeing scale, like what are sort of, strategies that have worked from a blocking perspective, both incentives as well as, other techniques you've used from your sides?
Amy, do you want to take that first?
Sure. I'm feeling a little bit like a broken record, but I think as you think about the inherent conflict between providers and health plans, I think it's about trust. I think neither party trusts the other party with their data because they don't interact in trusting ways in the rest of healthcare. So, one of my fears with AI right now is it won't actually make people's healthcare better. Instead, it'll just make providers better billing machines and health plans better denying machines, because that's sort of the structure. And then you put technology into a structure that isn't serving people, and it will just do that 10 times better. And so I think, and this is why I'm a big fan of value-based payment or shared alignment between purchaser and provider. You got to be in the boat together on behalf of the patient. The provider system has to be partnered with the health plan around the member ultimately to make their healthcare better. And that is just not how we've set things up. We've set this up as a game that does better when you don't trust each other. You're not going to share your data with someone you don't trust. So I know that was really in generalities, but to get people to start sharing data, you're going to have to get trust. To get trust, you're going to have to give them aligned incentives. To get aligned incentives, we're going to have to change how people get paid. That's sort of how I get to where we start.
Yeah, I think I've always told my team we're in the trust business. Back when many years ago, I co-chaired the State of Illinois Health Information Exchange. I was the co-chair, and they would ask me to leave because I was the, the evil health plan coming across. I don't have, I'm not naive that there's not always trust issues, but for attaining data and exchanging data with clinician communities today, I found the scaling of that has been incredible. I think I connected to 9 health plans just over the weekend, provider systems. I get charts from 55 miles from the US-Russian border today. So we're doing fairly well in the trust game because we're bringing capabilities that align to a value-based care platform mindset locally and nationally. As far as true information blocking, I think most of it's, if we're not aligned, because our number one thing is to align to the network contract. That's my number one guiding principle. So follow the money. With that, you have some of the trust. I put something in the chat about working with providers on legacy contracts and trying to get them paid more in year. Talk about fire in the future, in year payment, in 6 months payment. And that's 6.46% I put in there. There's a very, very large provider just across the river here, and I'm just south of Northwestern. So that's a lot of money for them on one contract that's spread across everything. That builds trust. I do get the information, not so much blocking, it's probably maybe some more information filtering. And that gets to behavioral health comments I made earlier, some other things that are limiters where if you had at least a behavioral health instance at a provider setting, the EMRs, some of them shut down sending the physical health. And so then all of a sudden you have a data silo. Then there are the vendors that have the information blocking and they just want the economics. We touched on that earlier. But I think it's really about getting over some of the legacy patterns of, we've never shared this information, although they have the ability to. But everything ties back to the, Krishna, you know this, right? So align to the network contract, put information where the clinician and patients do business, wherever possible, be multi-payer, because Blue plus government plus 1 or 2 commercials is going to get you 65%. That's provider office workflow as well as revenue. So you'll change behaviors. Standards is a guidepost, not an absolute. Avoid point solutions, i.e. portals, and acquire once and consume by many. So I think one of the other things with trust is that if you are just abrading the market with requests after requests after requests, they don't think you've got your game together. So stop that. And for the health plans, consume what we've acquired and bring the value in year. But again, I said the pure information blocking, it really gets back to probably just economic forces of some of these vendors.
I do think that there's a policy consideration here. Having built a health plan prior to launching BeWell, is the concept of the permitted use of operations. Data freely flows under treatment, and it is now starting to flow under individual access or patient right of access. When you get to operations, it becomes very sticky. And the reason that it does, and this was the great promise of TEFCA opening up to operations, is that there's 2 challenges to solve. One is that there are already BAA agreements between payers and providers that would be superseded by a national standard that said you can share for operations. But I actually think the bigger problem is operations definition is too broad. And the reason that it's too broad is because a health plan knows that if you obtain clinical information for any purpose, whether it is for prior auth, whether it's for an audit and desk review, it could be for quality reporting, is that you can use that clinical information for any other purpose under payment and operations. So the challenge becomes when a health system wants to share information to get in the same boat, because I completely agree that you've got to be in the same boat. If you want to share information for the purpose of value-based arrangements and being in it together, you can't use that same clinical record to then go bang a provider over the head on a retrospective review and claim that they were paid too much, or that use that same information in contract negotiations. So I think if you actually restricted the definition of operations in any type of a federal rule to the purpose of value-based care and only value-based care, not to be used for payment purposes, that you would actually get a lot more compliance and a lot more trust.
Excellent comments. Thank you.
Fantastic. I want to thank all four of you for your insight and your lived experience. It's been really a powerful discussion. You've helped us cover a lot of ground in this session. You are certainly welcome to stay and listen in as much as you can throughout the remainder of the meeting. At this time, we're going to take a break until 1:10 Eastern Time. Please join us then. We have a great next set of experts from our second session, which focus on the availability and effectiveness of digital tools for equipping patients with information about their health care. Look forward to talking then, and we stand in recess.
Produced by the U.S. Department of Health and Human Services.